All right, we now move on to the second half of the session. I've prepared a series of topics that I found interesting to discuss. And we're going to start with the first one, which is about non-criteria antiphospholipid antibodies. Well, as we've already reviewed, these non-criteria antibodies are those that are not included in the classification criteria. And, well, their role in APS could be in aiding diagnosis in seronegative patients. Also, in risk stratification for patients who have positive antibodies. And one of the limitations regarding their study and applicability is that these antibodies have a very broad spectrum. And as we've already thoroughly mentioned earlier in the talk, there are indeed currently no standardized techniques available for their detection. The first group of antibodies I'm going to discuss is the IgA isotype of anticardiolipin and anti-beta-2 glycoprotein I antibodies. These antibodies have been associated with the presence of thrombosis and obstetric morbidity, but they have a low prevalence and are frequently found in association with other antibodies. Moreover, it has been observed that their isolated positivity does not appear to have clinical relevance, and despite all this, and the fact that they are not included in the APS criteria, they are indeed included in the lupus criteria we have reviewed, state level. Therefore, there is currently insufficient evidence to support their routine use. To improve the diagnostic accuracy of APS, the antibodies against domain 1 of beta-2 glycoprotein, as we already mentioned in the introduction, are the ones that confer the pathogenic role or nature of the antibodies. And they are frequently associated with triple positivity. And when they are present, there's also a tendency toward higher antibody titers, which, as we have already seen, would lead to a higher clinical risk. Furthermore, it strongly correlates with the presence of clinical manifestations, both thrombotic and late obstetric morbidity, although its isolated positivity is not very high in seronegative patients. It seems that it may potentially be useful in patients with incomplete profiles, especially for additional risk stratification. And finally, the antibodies against the phosphatidylserine prothrombin complex. These antibodies are very common in patients with APS, especially in patients with a positive lupus anticoagulant test. And it appears that they are the main antibodies mediating the positivity of the lupus anticoagulant test. Therefore, its use is recommended in seronegative patients or those with a doubtful lupus anticoagulant test. And if they are positive, they would indicate a higher risk. Thus, they could help us both in risk stratification and as supportive evidence. For diagnosis, patients with incomplete profiles or inconclusive lupus anticoagulant tests